These are this strictly hardcore now, right? This is like the 12th round of the title fight when you're just completely concussed and you're dazed, and then somebody puts an ice pack on the back of your neck and it's like, do you want to be a champion? Get back in there and learn about anticoagulation. I appreciate you sticking with me. We're going to close it out. We'll try to make it fast and to the point. All right? This is how I understood the coagulation cascade in medical school, right? Bleeding starts, miracle occurs, bleeding stops, okay? Minor miracle. Not too far from the truth, though, actually, as we'll see, right? Because the old paradigm was this, right? You had the extrinsic pathway, you had the intrinsic pathway, you had to memorize non-ordinal cascades of numbers in order to understand this, right? Why doesn't the clotting cascade go 10, 9, 8, 7, 6, 5, 4, 3, 2, 1, right? Doesn't make any darn sense. Okay, this is the new paradigm. The new paradigm is all of these things are happening at once, and we're going to develop a mechanical understanding of coagulation that allows us to look at something as simple as this, which we're going to talk about, a thromboelastogram, and know exactly which product to give to correct the patient's coagulation problem. So we'll give you some background on oral anticoagulants. We'll talk about how do I know if this patient is therapeutically anticoagulated, right? This is one of the problems that comes up in the ED. Oh, I think I took my Eliquis on Tuesday. I think my last dose was Tuesday morning, and today I need a lumbar puncture, right? Can I do it? Is the patient still anticoagulated? I don't know. You know, what about patients with end-stage liver disease? They always have an INR that's abnormal, and it probably doesn't mean anything, right? How do we figure out what's wrong with them? And then finally, reversal. For non-bleeding and bleeding patients, how do we reverse vitamin K antagonists appropriately, direct oral anticoagulants, and so on? All right. Vitamin K antagonists, for all purposes here, is just warfarin, right? VKAs. Novel oral anticoagulants have been called NOACs. They're not novel anymore, so we call them DOACs, and that's what we'll use today to encompass all the non-VKA drugs. So here's a simplified version of the coagulation cascade, right? It all comes down to factor 10. Factor 10 becomes factor 10A when it's activated, and it catalyzes the conversion of prothrombin to thrombin, right? And thrombin, 2A, takes fibrinogen to fibrin, and it forms an organized clot. And then that clot is subject to intrinsic mechanisms of fibrinolysis, and that's the thing that keeps us from all getting DVTs every time we bump our shin against the coffee table or whatever, right? So warfarin, we've got some cows here up in Wisconsin eating some spoiled silage, right? And then they started bleeding to death, and people said, oh, wait, and they identified hydroxycoumarins from the spoiled clover, and they made this drug that was called warfarin based on the Wisconsin Animal Research Foundation, Warfarin, and the fact that they were hydroxycoumarins, and that became Coumadin, and that was, you know, first used as a rodenticide, as most of you know, right? You use it as rat poison. In Arizona, we have these horrible creatures called roof rats. They live their whole lives 4 feet above the ground, terrorizing you and your citrus trees. And they put these little tubes in the trees. These bait tubes in the trees. They wire them in there, and they've got this block of like cheese-flavored super warfarins in there. You know, the roof rats go in there and they eat the super warfarins, and then they start to feel unwell, and they go somewhere, you know, to meet their maker. All right, so vitamin K antagonist induces a factor-deficient state, right? It actually prevents gamma carboxylation of vitamin K-dependent clotting factors, which you know is 2, 7, 9, 10, C, and S. Lots of experience with warfarin, right? Jerry Hoffman likes to say the only reason warfarin is still around is because it works so bad, right? Like, most people aren't therapeutic most of the time, right? Or else even more of them would bleed, right? You can have this transient hypercoagulable state in theory from the inhibition of CNS when you are getting on warfarin, and so historically people were bridged with something like low molecular weight heparin. In practice, as you probably know in the outpatient world, nobody's really doing that anymore. If you have AFib, they're putting you on some warfarin and getting you therapeutic over a couple of days. Same thing if you have cardiac surgery, you got a fresh valve, they'll put you on aspirin on post-op day 1 or 2, and then they'll start introducing warfarin with no bridge. It takes 3 to 5 days for a steady state INR. Likewise, if you're trying to treat an INR in the emergency department by holding a dose or something like that, you're treating the INR from a couple of days ago. The DOACs, these are orally bioavailable. They have a much shorter duration of action. There's no need to bridge. They almost all depend on some renal clearance, and so renal failure can be a problem. And they have a pretty short duration of action, right? So when they first came out, everybody said, no big deal that we don't really have an antidote, right? You'll just wait it out. The patient won't bleed to death while you're waiting, because it'll happen so fast. Turns out that's not always the case. But routine testing isn't needed to maintain therapeutic levels, and so that's been kind of an advantage, and as we've seen, they've kind of taken over practice. I'm going to say just a little bit about direct thrombin inhibitors because this is the least prescribed of the classes of DOACs, right? Dabigatran was one of the first ones to come out, and now has sort of fallen into disfavor because there's better drugs. But it's a direct inhibitor of thrombin, 2A, so you can't make organized fibrin clots. Hirudin was the prototype of this class. That came from leech saliva, right? We still use in cardiothoracic surgery and ECMO, we use bivalirudin a lot, which is another drug derived from this class. It's a nice infusion, and the nice thing about that compared to heparin is that once you get it right and the patient's therapeutically anticoagulated, unlike heparin, you don't need to check it every few hours and keep going up and down because it gives you really predictable anticoagulation. Dabigatran was approved in 2010. Depends on renal function, and it has a half-life under those circumstances as normal renal function, 12 to 17 hours. Had some benefits over warfarin that we already discussed. You can take it orally, you don't need to check a level, anticoagulates you right away, doesn't require monitoring. Minimal interactions with food and drugs, there are a few exceptions, but it's definitely not recommended in renal failure or patients with markedly impaired hepatic function. And the problem, of course, as we all know, is that patients don't always read the book and decide not to go into renal failure on that Tuesday or that Friday. How about factor 10A inhibitors? So this is really easy to remember because their names all have Exaban, right? And the XA is for 10A, right? So they block factor 10A. You can't make prothrombin into thrombin. So we have rivaroxaban, apixaban, edoxaban, and betrixaban. The first two are the most commonly used in the United States. Xarelto and Eliquis is the trade names. Renal and hepatic clearance, very, very rapid onset of action. Here's some half-lives, just so you can think about this. You don't have to memorize any of this stuff, but just to have a rough idea, right? Because we're going to say you don't have any level. We'll talk about how lab tests are or are not helpful. So what you really want to know is, was the patient's last dose before they need this surgery, urgent procedure, or they have ongoing bleeding within 3 to 5 half-lives of the time that I see them? And so this is where they are. They range from 13 hours on the long end for rivaroxaban up to 25 hours for betrixaban at the longest. They can still have some drug interactions. Renal dysfunction creates a problem. There are modified dosing regimens for renal dysfunction, but as a rule, if I had renal dysfunction, I wouldn't want to be put on one of these drugs because it tends to be a moving target. And then if I have impaired drug clearance, I'm going to get very, very, very anticoagulated very quickly. So how do we know if this patient's therapeutically anticoagulated if they don't look like this, right? We say, yeah, you're probably therapeutically anticoagulated. So we have our usually available tests, and we'll talk about how they are and aren't helpful, right? We have PT, we have INR, and we have APTT. Then we have a bunch of tests. Sometimes they're helpful for these drugs, but we don't usually have them. They had them when they were doing these drug trials, right? Things like dilute thrombin time, eccrine clotting time, which is derived from the venom of the viper Echis carinatus, right? That's pretty cool. Calibrated anti-10A assays, right? So most places have an anti-10A assay, but it's usually calibrated for use with unfractionated heparin, right? A lot of places have gone away from PTT monitoring for heparin in the hospital, excuse me, to 10A monitoring. And you can't use the unfractionated heparin 10A assay for things like rivaroxaban or apixaban or low molecular heparins. And then you have dilute Russell's pit viper venom time. Nobody knows what to do with that. I don't think anybody has that test. Okay, so how can you use it? Well, if you are therapeutically anticoagulated or greater with dabigatran, your PTT will be qualitatively elevated, right? So how high it's elevated doesn't tell you how anticoagulated you are, but the fact that it's elevated tells you there's still some drug around, and the effect of that drug is probably therapeutic or perhaps more, right? Same thing for rivaroxaban. If your PT is elevated, right, not INR, because remember INR was just a way to standardize PT so that different labs could do warfarin dosing, right? So just look at the PT. If the PT is up and it's not normal, so greater than 1.6, then the patient probably is therapeutically anticoagulated or more on rivaroxaban. Problem for apixaban is none of that stuff works really well, and then all those other tests, the sexy tests we talked about, are not routinely available. So let's talk about my favorite thing, thromboelastograms. So where I work, they made these Shepherd Ferry, Hope-style memes of everybody. And mine, I had two. Mine was TEG and DC Foley, So I guess I order a lot of TEGs, and I guess I ask for a lot of Foleys to be DC'd. I really think they should make a meme out of that. We should just take the Foleys out. So how does a TEG work? Does anybody have TEG at their facility? Anybody using it? No? I bet that a lot of, anybody work at trauma centers? Trauma centers. So some trauma center people. So if you work at a trauma center, or if you work at a place where they do hepatobiliary surgery, or if you work at a place where they do cardiopulmonary bypass, you probably actually have this, but you may not know it, and you may not know how to get it. And I think in the future, you're going to probably want to use this. So I'm going to tell you a little bit about it and why I think it's so cool and why I think it's so good, okay? So a TEG, you take 0.36 cc's of whole blood in this little cup, basically. You dip a pin in the cup, and the pin is attached to a little strain gauge, right, an electromechanical strain gauge. And you spin this thing around, you put in a little bit of kaolin clay to get the clotting started. And you spin this around, and you develop a little graph of the strain, right? And the graph looks like this. And so this is a clot that forms, right? So you have clot initiation over here, and you measure this time until the clot starts to initiate in this little cup, and that's called the R time. Then you have a constant called K, and that's the time it takes the clot to reach a certain amplitude. You have an alpha angle, and that's the angle with which this clot approaches this maximal amplitude. And you have max amplitude, and then TEG is typically called a TEG 30, okay? And so then you leave it for 30 minutes, and you see how much thrombolysis occurs over 30 minutes, okay? And what's really cool about this is each of these things corresponds to the need for a particular blood product or factor, okay? So if your R time's really long, this is a factor problem, right? If your K is long or your angle is low, that's a problem of clot amplification, so you need cryoprecipitate, you need fibrinogen. If your max amplitude is low, that's a platelet problem. So maybe you're on aspirin, or maybe you're on aspirin and Plavix, right? Or maybe you just don't have enough platelets. So this is really, really helpful. And then, if you have all this excessive fibrinolysis where you form this little stringy tail, right, or the amount that you lyse within 30 minutes, so-called LY30, is high, right, then maybe you need an antifibrinolytic, like tranexamic acid, like we talked about, or aminocaproic acid. So this is really cool. So what a lot of big-time trauma centers are doing is, when they take the patient to the operating room from the trauma bay, right, you can do this thing, and you can have the results of this graph displaying as they form, right? And so they put this up, and so as the surgeons are operating, they're looking at the patient's immediate coagulopathy as it evolves, and saying, oh, wait, the R time's really long, please give me some FFP, or give me some PCCs, right? Oh, wait, this angle's really shallow, can you give them 20 of cryo? Max amplitude is low, please give me some platelets, right? They see some fibrinolysis forming, they say, give a gram of TXA, right? We use this all the time in liver transplant surgery. It's being increasingly used in cardiac surgery. And the other thing that's really cool is we know, and there's a really good New England Journal article on this from a few years ago about end-stage liver disease patients, right? They all have these wacky INRs and PTs, and we don't know what they mean, right? Some of those end-stage liver patients are actually really hypercoagulable, even though their INR is 5. Well, the cool thing is the TEG allows you to distinguish between them, right? So you find yourself needing to do a lumbar puncture on an altered liver patient who has cirrhosis and an INR of 3.6. Number one, it turns out, as was recently published, giving those people FFP doesn't help. It doesn't, even if they are coagulopathic, it doesn't make a lot of thrombin in liver patients, right? So it's probably not helpful. And this what lets you show that if the TEG is normal, you can do your procedure. Don't worry about it. You can do it. It's safe, okay? So when we have patients that are on rivaroxaban or apixaban, particularly apixaban, because you don't even have that qualitative data to guide you with an elevated PT, if you can get a TEG, the R time on the TEG is pretty reliably prolonged in the presence of these DOACs, okay? So maybe ask around at your center. See if you can get this. A lot of times it's that the surgeons have this and they just don't want to share, okay? But it's a point-of-care test. It only takes 30 minutes, and they're not doing them all day, So they can free up the machine when they're not doing scheduled surgeries. And we actually have this where, for patients, for example, who are on ECMO or stuff, we'll bring it right to the ICU and put it at the patient's bedside, and you run a TEG at the bedside so you can figure out what to give them. It's pretty cool. Reversing anticoagulation. What do you want to know? What's the severity and the location of bleeding? Is the patient hemodynamically stable or unstable? Can I wait it out, so to speak, with these DOACs? Or am I well inside 3 to 5 half-lives and I have to do something to reverse them? Is it medical or surgical bleeding, right? So dose of anticoagulant, when did they take it? When was their last dose? Are there contraindications to full reversal, right? Does the patient have a mechanical aortic valve that people are going to be real nervous about reversing, and they're just going to want to hold warfarin and give some blood? Maybe so. And then labs and tech, and we just talked about the limitations of those. So we're going to kind of define things as so-called universal reversal agents, and then we'll talk about class and drug-specific reversal agents. Universal, vitamin K is not really universal, right? Because most of us have adequate vitamin K stores and we have adequate amount of factors, so it's really universal only in the setting of warfarin and superwarfarins. But it allows you to reactivate your vitamin K-dependent clotting factors. It can take many hours to work, even if you give 10 of IV vitamin K, right? So we restore and we replenish. We restore the ability to carboxylate clotting factors, and then we replenish them by giving something else, like fresh frozen plasma, or more ideally, prothrombin complex concentrates, or PCC, right? Vitamin K, we said give it IV. It's only good if you want rapid reversal if you want not so rapid reversal that's durable, right? Like I'm taking this patient off their anticoagulant for a while, right? So like we don't love to give vitamin K to people that have mechanical support devices or mechanical valves because it's going to be hell getting them re-anticoagulated in a couple of days or a week or so. FFP, we know there's large volumes. FFP, by the way, is the product that's most associated with TRALI. So one of the reasons why the rates of TRALI is like, 1 in 50,000 and 1 in 500,000, nobody really knows, is because the rates of transfusion-related acute lung injury have gone way down over the last few years, and that's because we use so much less plasma. PRBCs don't give you TRALI very much. PCCs, it's a pooled human plasma product, it's virus inactivated, it's a powder, it's got a little bit of heparin in there to keep the clotting factors from becoming activated. So it comes in different flavors. The one that we have in the United States is a 4-factor non-activated PCC called Kcentra is the trade name, right? And it also has a little bit of protein C, S, and Z. And then there's a few activated PCCs that you can get, but we almost never use because they're so prothrombotic. One is recombinant factor 7A, right, which has a track record of causing things like MI and stroke in trauma patients when we try to fix them with that. And then FIBA, which is factor 8 inhibitor binding activity, which is a product that's usually given to hemophiliacs. They have a lot more prothrombin than FFP, high concentration of factors, really low volume, give it really quick, works great to reverse vitamin K antagonists in severe bleeding. Can be thrombogenic, not terribly thrombogenic in the literature if you give it at a moderate dose, 25 to 50 units per kilo. There is a theoretical risk of HIT that's never actually been reported in human beings. That's just because of the tiny amounts of heparin that are in there. And DIC is a contraindication to use, and that's because the treatment for DIC isn't to fix the clotting factors, right? It's to fix the problem, right? Whether it be sepsis or whatever it is. How about some drug-specific reversal? So warfarin, we said reverse warfarin by restoring and replenish, right? Restore production with IV vitamin K. That's going to take some time, but it's going to give you durable reversal. And then replenish factors. Ideally with PCC, if you don't have PCC, you can give FFP. You might need kind of large amounts. The volume might be prohibitive, right? And it takes some time to get the stuff thawed. This is the ACCP guidelines. This is the thing that I usually Google if I have a patient who's not bleeding and I need to know what to do with the warfarin on the basis of a particular INR, right? So if you Google chest guidelines, Coumadin, then this is the chart that you get basically, right? So whether to lower or omit the next warfarin dose, when do you recheck the next INR, how much do you dose it if you need to reverse them, what if their INR is greater than 10, and so on. This is a table I showed you earlier, just a reminder that it's really straightforward, right? For INR of 2, FFP is 1. For 2 to 3, it's 2. For 3 to 4, it's 3. And it goes all the way like that up until 4. And then when you get to 4, it falls off. And so if their INR is greater than 8, you're going to need some unknown amount of PCC, or better yet, give them 50 units per, unknown amount of FFP, or better yet, give them 50 units per kilo of PCC and call it a day. Dabigatran, again, not very commonly used right now, but there is an antibody, a monoclonal antibody to it called idarosizumab or Praxbind, or in trials they called it adabifab. And it binds irreversibly, it neutralizes dabigatran, it seems to work pretty well, doesn't seem to have an effect itself on platelet aggregation, which is nice, has a pretty short half-life if your renal function is normal. This was the reverse AD study, 503 patients with dabigatran-associated bleeding, mostly GI bleeds and intracranial bleeds. 100% labs reversed with 5 grams idarosizumab. We said that isn't the best way to look at these things, right? You want a patient-centered outcome. But the median time to uncontrolled bleeding cessation was 2.5 hours, which is pretty reasonable. Median time to procedure, 1.6 hours. And peri-procedural hemostasis was normal in most. The exabans, right? Rivaroxaban, apixaban, doxaban, they block 10A. So how do we reverse them? We said there is this novel drug called andexanet alpha that's approved and $50,000 for a full dose. I don't think the data justifies using it, even if the expense were somehow able to be justified in a sane society. What I use is 4-factor PCC, 25 to 50 units per kilo. That helps get hemostasis in most patients with bleeding events on DOACs. Thrombosis rate is pretty low. Again, this isn't in the best, highest quality, double-blind, placebo-controlled RCTs. But if you look at a lot of people that got this, the thrombosis rate in these folks is pretty low. So retrospective data supports the use and safety of PCCs for reversing 10A inhibitors. And it can be a little bit hard to distinguish cessation effect from the treatment effect in acute bleeding because these things do go away pretty fast. And it always takes us a little bit longer in the hospital to do the reversal that we think we do so quickly. Andexanet alpha, we talked about the Annexa-4 study earlier today. 12% deaths at 30 days and 11% of those patients had a thrombotic event. That's a lot for a study in which there was no control arm or comparison arm, for example, with PCCs. So hard to know what to make of that. And for now, our shop considers this not really ready for prime time. So for severe bleeding on a vitamin K antagonist like warfarin, supportive measures, consult whoever you need to if you need IR or surgery to control surgical bleeding. Stop the warfarin and antiplatelet drugs, vitamin K, 10 milligrams slow IV, and then I would give 4-factor PCCs. For severe bleeding on dabigatran, it is dialyzable, and this is actually what we did before there was a Dabifab. And it was like, had a patient who was bleeding out who had just taken a couple of doses of dabigatran or taken a dabigatran overdose, and it was like everyone, was like, who wants to put in the dialysis catheter? Anyone? Anyone? Right? You'd be like, intern, you want to do a dialysis catheter, don't you? Right. So now we have a better way. We have a idarucizumab, 5 grams divided into 2.5 gram boluses, each given over 5 to 10 minutes. 10A inhibitors, again, stop the drug, blood, supportive care consultation. They talk about considering charcoal, unlikely to be useful, right? If you just took a dose, it's going to decrease the area under the concentration time curve for that dose, but it's not going to get rid of the stuff that's in your body. So what you need to do is overwhelm it stoichiometrically by giving a whole bunch of PCCs, and you can think about whether or not you believe in andexanet alpha, in which case it's an 800 milligram load and then 8 milligrams per minute for 2 hours. And what happens after that 2 hours to date is still unknown in the literature. That's it. Thank you very much for your attention. It's been a real pleasure talking with all of you. Thanks again.